So here you are watching Coblation Glossoepiglottopexy in a 37-year-old male. Very bad epiglottic collapse, and you can see the epiglottis during intubation has actually gone inside and got retroflexed. So why I am not removing it now? And you can see very nicely the vessel in the glossoepiglottic glossoepiglottic ligament. Glossoepiglottic ligament, the lateral glossoepiglottic ligament containing the vessels. So if you operate in these lateral areas, you are bound to get brisk bleeding. In the median glossoepiglottic ligament area, which is this area, you generally do not have those prominent vessels. And I'm only coagulating. I'm not ablating. I'm coagulating with coblation wand at a setting of 4 for coagulation. I'm right in the midline. This patient is unable to tolerate CPAP. This is the median glossoepiglottic ligament. I'm coagulating the whole ligament. These lymphoid tissues may be ablated, but first I'm coagulating it so that the blood supply goes down. And after that, if needed, I will ablate. Because this area can turn really dangerous if there's a bleeding in the post-op period. So this lymphoid tissue I am ablating now. But my main aim is to coagulate on the median glossoepiglottic ligament area. This is a large lymphoid tissue which I need to ablate, which I am ablating now. Now see, be extremely careful, because if you open up any vessel, alright, now what I am doing is, see, this is the lateral glossoepiglottic ligament and the vessel. I am just coagulating. I am not ablating at all. And I am restricting myself to midline. I am following the tube. Now my next step will be to pull out the epiglottis. Alright. I'm just following up the tube. While intubation, the epiglottis has been, because it was so retroflexed epiglottic, it just went inside. Can I have some? Oh, this is the epiglottis. So then I'm still coagulating the median part. I will continue with this. Alright, can you press from outside? That's the epiglottis. Yes. One sec. I want to still coagulate and do my work completely, and that's the epiglottis. Can you see? That's the epiglottis which has come out, and I'm only coagulating the median area. Now see, the lateral glossoepiglottic ligament is here. This extra is nothing here. This is not obstructing. This is the only thing which is obstructing. So let me first coagulate it. And then remove this extra bit of lymphoid tissue by ablation. Alright. The lymphoid tissue is ablated, but I am only coagulating the median glossoepiglottic ligament. I am not going too much laterally, and This area is not causing the problem. So if you want, you can remove this lymphoid tissue by ablation. You see this? You see too much of it, you can remove it by ablation. By be very careful while ablating, because that's when you are not coagulating the vessels. All right. So I'll just give a little bit more extra energy into this area, because this is where we want maximum fibrosis to happen. Just going a little bit laterally, and that's the vessel. So I'll remain away from the vessel, just coagulating a little. Still a little bit of lymphoid tissue which I want to ablate very, very carefully. Coagulating again. That's the ligament. The whole ligament I'm coagulating, trying to remain in my correct position. And using a 70-degree scope, you can use a 45, you can use also a 30, but 30 becomes a little challenging. 45 and 70 are much better. 45 is the ideal. So this is glottoepiglottopexy. You need not coagulate this area. All right. Let me see if I need to do a little more. Not really. I have already done maximum. I'm giving good amount of energy into the median area. Just not happy with this lymphoid tissue, but I do not want to get into the vessels. If I go deep here, I'll get into the vessels. That can bleed, so I'm just restricting myself. Alright, so this is a 10-minute surgery, less than 10-minute surgery, which changes the fate of this patient who was unable to tolerate the CPAP also. Absolutely maintained BMI. He cannot do a sleep study because of the sleep apnea. And I'm not even removing all the lymphoid tissues from here. I may just do a little bit of coagulation more, because this was a primary epiglottic collapse. This is not a tongue-based collapse. You do not need to do too much. Only a proper glossoepiglottopexy should be good enough. So that's the final uh, result, and hopefully this patient will not require any PAP therapy, any other therapy for his epiglottis. Now see, I want the epiglottis to remain like this. Therefore, I'm giving little more energy over here at the setting of 4 for coagulation. If there is any amount of lymphoid tissue here, it will still not fibrose. So I just want to remove this lymphoid tissue completely. Can you see this? Now there is no lymphoid tissue, and this will fibrose to fullest extent. Alright, thank you for watching.